Yeah, okay, so possibly partial intervention. Maybe the person will decide somewhere farther down the road that they're willing to start again. That certainly happens a lot. And also, as you suggested, you could also collect complete follow-up information. And therefore, we'll talk about in a minute, intention to treat analysis. You'll really be able to do that. So, so we talked about option one, you save money. You also, if you're trying to mask long-term negative effects, that may be both an advantage and a disadvantage, as you may tend to not see long-term negative effects. So, say, in the extreme case that a drug maybe increases mortality, but 3 months down the road after you stop taking it, it still has an effect. If you stop following the people, you won't see that. So, the monetary factor, that's a real thing. I mean, if you're on a tight budget, which everyone is, saving money may be a consideration. But I think absent that, it's certainly an advantage if you can to continue to follow people all the way through, even if they stop taking their medications. And again, the advantages here are that you can do your formal intention to treat analysis. You could look at, you have the option, if you have the full follow-up, to go back and do a per protocol analysis. So just look at the effect of the drug while the people were actually taking it. But you can only do that as well as the ITT if you collect all the data. And of course, it is more costly. So that's something to keep in mind. So that kind of brings us into this area of intention to treat, or ITT analysis. And I think, again, it's worth going back and talking about this in a little bit of detail. It was a coin originally termed in a textbook on statistics in 1961 as sort of one of the commandments of the RCT Bible. And the original definition was all subjects will be analyzed according to the treatment group they were originally intended by the randomization process. In other words, if you randomize somebody, whether or not they took the pill or not, you should analyze them according to that randomization. And the way this was violated, or is still violated sometimes, is say you randomize someone to aspirin, but they say, I don't want to take aspirin, I want to take placebo. Or you randomize them to placebo, and they say, oh, I want to take aspirin. And so they take aspirin. And then if you analyze them, even though they're randomized to placebo, as if they were taking aspirin, that violates the ITT principle. And I think that the original definition was somewhat narrow, but now it's generally interpreted as including all patients, regardless of whether or not they satisfied the entry criteria, whether treatment was actually received, or they withdrew or not. No matter what, you include them in the analysis. And again, I'll talk about this in a little more detail. I think the true meaning of the term is kind of ambiguous. And the reason I'm kind of giving you this detail is because when you read a study and they say, we did ITT analysis, what that means might be ambiguous. So if you care about the quality of the trial, you might want to look at it in more detail. And this is mentioned in the Hollis discussion. All patients included in the analysis, even if they didn't start the intervention. That may or may not be done, and still people may call it ITT. Patients who were randomized but did not meet inclusion criteria should be included in a true ITT analysis. So, for example, the example I mentioned before where you had to be 60 years old and have a certain systolic blood pressure, if you get all done and you find out, oh my God, we included people who were 58 years old and didn't quite have a high enough blood pressure, the true ITT suggests that those people should still be included in your analysis, even if they didn't originally qualify, as long as they were randomized. All patients should be included regardless of compliance, and that all of this implies that you should ascertain the primary outcome on all people randomized. So this is kind of the most rigorous meaning of ITT. So what are the purposes of ITT? Well, the main purpose from Hollis is to maintain the validity of the original randomization. When you randomized people to active or placebo, you assured that those two groups were equal and that they can differ really only by chance. So if you start excluding people based on post-randomization variables, for example, whether they took the pills or not, that could create bias, and you no longer have two groups that are comparable. And there's a really nice example, which I'll talk about in a minute, in the medical surgery example in the Hollis study. Secondly, doing the ITT makes the clinical trial more like the real-world situation. Clinicians in the real world have been known to deviate from protocols, as we all know, and especially for pragmatic trials, for behavioral interventions. It's probably more an estimate of what would happen in the real world to do an ITT analysis and to include everyone in the analysis. Although I think we're probably all aware of the fact that as much as we'd like to be able to generalize clinical trial results to real patients, that clinical trial patients are sort of a special group. So you probably have to realize, you'd have to be naive not to realize that generalization is often a little bit problematic. But so this is the cow. Is ITT is considered a sacred cow? And so I think, yes, it is. But again, you need to beware of someone who's trying to give their study this patina of rigor just by saying they did an ITT analysis. So the term ITT is used in many different studies. It probably does mean that all randomized people, or most of them, were included in the analysis and classified according to the original treatment they were randomized to. That's generally done now. But what are the differences in the meaning? In practice, ITT does not always mean that participants were followed beyond stopping medications. So it doesn't always mean that. So that's something you may want to check out. And then it's very common to say now this term modified ITT or MIT analysis was done. And that means they only included those who received at least one treatment, they took at least one pill. So while this is very commonly done, again, it strictly speaking is a violation of the ITT principles. Now, how are ITT principles applied in real trials? In the Hollis article, they looked at 250 trials in BMJ, JAMA, Lancet, and NEJM, and they found about half of these trials reported using the ITT, but found that most trials with ITT claimed violated one or more of the principles. And so again, these are sort of details, but still important to look. So what are some alternatives to an ITT analysis? Okay, one alternative is something called a per protocol analysis. And what this means is if all participants are followed, regardless of adherence to medication, that gives you some options of doing several types of analyses. And there are different flavors of these per protocol things. So again, if someone says per protocol, I'd ask the question, what do you really mean by that? Typically, you might include only those patients who took all of the study meds and completed all the visits. That'd be a really rigorous definition. 100% compliance, 100% medication. Anybody who even had 99% compliance, you delete them from the analysis. A more practical thing might be that you include all patients, but only for the time they remained on study medication. So if some of the patients, say, took medications, maybe they took 80% of them up to 6 months and then they stopped, you could only analyze that period in the trial in a per protocol analysis. And once again, if you obtain complete follow-up on all patients, you can run several different types of these per protocol analyses. You can recognize that they're probably biased in one way or another. But again, if you can triangulate all these results, if your ITT and all of your per protocol analyses give you the same results, or in a lot of cases, the ITT gives you a null result, but the per protocol may give you a positive result. And that may clue you into the fact that, well, maybe the drug really works, but it just people didn't adhere. So I think there certainly is value in doing these per protocol analyses. Don't always have to do an ITT. So this is actually an interesting example in the Hollis paper. And what they talked about is this study where they randomized people to medical or surgical intervention. And again, they're looking at a bypass surgery and restenosis rate. But what happened was, because it was a surgical study, they randomized people to either medical or surgical, but then regardless of the randomization, what they actually got may have been different. So for example, that second group, let me see if I can use the pointer here. That second group were randomized to medical, but actually the doctor decided to do the surgery, even though they were randomized to medical. And then they have the number of survivors and number of deaths. Mortality here was the main outcome. And so what they did in this analysis is, here you go, they looked at different ways of analyzing the data and to see what the difference was in the results. And you can see the results do vary. So